Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today, our topic of discussion is about diabetes and its different complications in eyes. What are their signs and symptoms and possible management? If we talk about eyes particularly, diabetes, high blood sugar level basically affects retina, the area of the eyeball where the image forms, and that image through the optic nerve is taken to the brain. So this is the one of the most sensitive parts of the eyes, and it is affected by diabetes. When we talk about diabetes, diabetes is basically, or high blood sugar level is a disease of small blood vessels that we call in our medical language microangiopathy. That is, small blood vessels are affected. Diabetes can affect anywhere. It can affect eyes, brain, skin, bones, heart, you name it, and it affects. And if I say it is almost an epidemic nowadays due to our irregular dietary habits and our lifestyles, I will not be wrong. It is just like an epidemic. And in eyes, when we say, it affects other organs, particularly retina. So how does it affect the small blood vessels? This is a question. Two mechanisms. Number one is it occludes the small blood vessels. Occlusion happens by different mechanisms. And number two, the small blood vessels become leaky. They start leaking. The blood starts oozing from them. Their holding capacity of the blood is decreased. So when two mechanisms happening over there in small blood vessels in eyes, that is, the blood vessels are getting occluded, getting closed, and they are becoming leaky. So now let's have a look at this photograph, which is shown in this slide. Here we can see in the retina, there are hemorrhages. Blood is leaking from the blood vessels and it is deposited over there. And as the blood gets deposited over there, it causes swelling of the most sensitive part of the eyeball, that is macula in the retina, and vision is compromised. So this is the very important thing which is shown in this slide here also, that all around their blood vessels. So not only the blood comes out from the vessels, there are also cholesterol or lipid deposits which get deposited in the retina. So all these things are happening over there. So this is a beautiful slide which is showing us diabetic retinopathy, that is high blood sugar, persistent high blood sugar, how it is damaging, it is affecting. It is beautifully shown in this slide. Another slide, here it is shown a milder form of diabetic retinopathy. You can say the things are beginning up, they are starting. Here on one side, that white circle is the optic nerve, optic disc, which is conveying all messages to the brain from the eyeball. And if you see, there are two blood vessels, upper and lower. The area between these two upper and lower blood vessels is called macula, and it is 4500 micrometers area. If I say that this area basically deals with 90% of the vision, I will not be wrong. And when we are managing diabetes in eyes complication, we try our level best to preserve vision in this area, that is macula, that is between these two blood vessels, upper and lower, 4500 micrometer area. So this is relatively early stages. We will discuss about the proper scientific classification later on, but just to make it familiar to my respected audience who are not very much aware of the medical terminologies, this is some early stages how blood is coming from there, the blood vessels, and getting accumulated. So as I mentioned earlier, that the blood is getting deposited, and at the same time in the retina, because of ischemia, because of not proper delivery of oxygen, certain factors are released which we call vascular endothelial growth factors. On in simple language we can say that in diabetic patients, retina start developing new blood vessels. It is a response from the eye. When oxygen is not getting properly supplied and all these things are happening, the retina produces those factors which we call VEGF, and new blood vessels are formed. But the problem with these new blood vessels are that these vessels are not stable. They are fragile, they are leaky. The blood gets leaked from them and get deposited. So when we see over there new blood vessel developing, that is something really serious. And at this stage we call it that now diabetic retinopathy has entered into a stage that is proliferative diabetic retinopathy, that is the proliferation of the blood vessels is happening. So as I mentioned earlier, that we have to control it, and our target is to preserve that central area. So over the years, the medical scientists have developed a technique which is we call laser. You must be familiar with it, and some members of your family or around must have undergone this procedure. But what is the basic reason and rationale behind it? We apply lasers in the periphery, the region I mentioned earlier, and it is shown in this photograph, sparing that central macular area. The laser dots are applied over there in 2 to 3 sessions, and its numbers can vary and go up to 1000 plus. Why we do it? Actually, the physician destroys the peripheral area. When that peripheral retina is destroyed, there is no more release of those VEGF factors. When there is no release of VEGF factors, the blood vessel forming factors, no new blood vessels are formed, and we control the disease this way by the lasers. We call it pan-retinal photocoagulation, PRP, that we have applied lasers in the periphery and we have controlled it. And now the new blood vessels are undergoing involution. They are getting suppressed. And so we call it involuted PDR, that is decreasing over there. The things are settling down, those new blood vessels. Why we are worried about these new vessels? Because they are always a threat over there to the vision. They will always leak blood. They will make complications, which I will show you in the later stages. But the reason is we are applying laser burns over there to control it. So in this slide, it's not very good quality, but if you please concentrate in the peripheral areas, you will see dots over there. These are the laser dots which have been applied by the physician, the ophthalmologist, to control proliferative diabetic retinopathy. This is another slide to show you how the lasers are applied over there. Square pattern is taken over there and applying in different areas just to burn the periphery and sparing the central area, so that no more VEGFs are released and so the blood vessels will not develop, and the which are already present, they will undergo involution and suppression, and there will be no blood in the eyes. Along with this lasers, the other thing which is used and very common nowadays is injections. Physicians apply injections in the eye, very safe procedure. And these are anti-VEGFs. They come with different names and different compositions, chemical salts. If I talk about scientific name, bevacizumab, ranibizumab, and other, they are available and they are being given to control these factors, and these are very effective in controlling the proliferative and controlling the new blood vessels. But sometimes if the patient does not present in time, if the patient does not take good care of himself, his blood sugar level is not getting controlled, he does not come to physicians properly for checkup, the things are missed because of any reason, then this thing happens which is shown in the eye. The new blood vessels which form over there, they are abnormal, as I mentioned earlier. They are not strong blood vessels. And what happens, that along these blood vessels, scarring happen. If I use the normal term, layman term, we call it fibrosis, fibrotic changes over there happening. And along with these, wherever these blood vessels glow, fibrosis happen. And fibrosis are like attractions which pull a very sensitive part of the retina and it detaches over there. And that is called tractional retinal detachment. This form of detachment is in diabetics, usually we see that the traction is there. There is a pull from these blood vessels which are abnormal, which have been formed and which have got fibrosis over there. They are now detaching the retina. So in this slide, you can see the fibrotic changes are in the central area. The macular area is threatened. The slide, another patient. Here you can see extensive fibrosis over there. In the proliferative changes, already happened, new blood vessels and fibrosis all over there. And what is happening? This fibrosis is pulling and detaching the normal retina. Now the things are getting advanced stages. Even in these stages, if we find, we try to go for the laser as much as our view is possible. Wherever we see that retina is attached, we apply lasers, keeping in the mind that sometimes the laser spots also add to the attraction, to the pull. So very carefully at this stage, the lasers are applied so that the lasers do their job and do not aggravate the situation or worsen the situation. So this is another very beautiful slide showing here the proliferative plus fibrotic changes and leading to tractional retinal detachment. Same patient, earlier we saw the posterior pole and now the superior. One thing to mention, that diabetes usually affects the posterior pole of the retina, the posterior areas, and then it starts affecting the other areas. So let's have a look at this slide. Again, fibrosis is happening, tractions, all those things which I mentioned earlier. The patients, the first slide which I showed you, the fibrosis, this is the other eye of that patient. But in this eye, there is tractional retinal detachment plus there is a hole, there is a break in the retina, and through this break fluid went over there and it also causes, which we call the second type, rhegmatogenous retinal detachment. So both types going on in this patient. Traction plus there was a break, fluid went into it and when there is fluid behind the retina, it also contributed to the detachment. So this is the other eye of the patient. The first slide which I showed, central area fibrosis, this is the other eye of the patient. Many times you must have heard that the physician asks the patient to go regularly OCT test. This is an investigation, and it gives us a quantitative analysis that how much fluid is there in the macula, that the area which I mentioned earlier in the retina between those two blood vessels. Now it is shown the cross section. The OCT shows us all the layers of the retina, and here we can see the fluid which is shown, and there is thickening, and also in the red circle, the circle forms over there, it shows us how much fluid has led to the edema or swelling. This is another cause of decreased vision in diabetic patients. So earlier I mentioned fibrotic leakage of blood, hemorrhages, detachment, plus macular edema. Many patients come where we do not find any changes of proliferative new blood vessels, but they have got this fluid which is shown in the cross section here, and the fluid which is shown in the black circles over there and elevated over there. So this happens over there, and we have to manage these patients with injections. As I mentioned, bevacizumab, ranibizumab, other anti-VEGFs. They are applied regularly as per the situation, as per the condition, and they are very effective to control the swelling. But the point here is that you do lasers, we do injections, and fibrotic changes I mentioned, we go for surgery also, because it is detached. We have to do surgery also to make an attachment of this area. We do whatever we try. But the thing is, if the patient's blood sugar level is not controlled properly, it is as if we are adding fuel to the fire. One side, and the other side, we are trying to control this by putting water. So very important that blood sugar level should be controlled, plus blood pressure level, hypertension, that also must be controlled, because they are aggravating factors. Sometimes we cannot see, there is cataract, so much blood is over there, we cannot see, we cannot take the photographs which I showed earlier. In these situations, ultrasound helps us. We call it B-scan. This is the photograph of the same patient. Here you can see how the retina is detached, except at the attachment of optic nerve, where it is strongly attached. Otherwise, it is totally detached. You can see it is in front of, it is not applied properly. There is a dark space in the posterior area showing us detachment on the ultrasound. It is very helpful when there is hemorrhage, we cannot see, or there is cataract. So we also use ultrasound, that is B-scan. When we talk about these diabetics, there are a number of complications. We have covered macular swelling, edema, diabetic macular edema. We have covered fractional retinal detachment. We have covered hemorrhages, bleeding in the eye, all these things. But in the earlier session I mentioned VEGF role. These are very problematic factors, because in human eye there is a balance between VEGFs and anti-VEGFs, and whenever that balance is disturbed, these VEGF factors not only affect the retina, they come in anterior portion of the eye. And now this is here, I have tried to show you, my respected audience, new blood vessels in front of the iris pigments. You can see those red dots over there. So this is now NVI. new vascularization on iris. This is something very alarming. If these things develop, it means the patient is now going to develop a very challenging form of the glaucoma, which we call new vascular glaucoma or these vessels related glaucoma. It is very challenging even for the glaucoma consultants to handle it. So in this diagram, in this photograph, we have shown new vascularization on the iris. How it is happening? Same problem. The VGFs are causing over there, they are affecting, they are putting their effects, and it is developing over there. Beautifully shown in this. The photographer has shown here in the cross section, he has made a slit of the beam of the light, and he has shown over there the new blood vessels on the iris. The problem with these blood vessels are when they are in the iris, they go into the angle over there and they close the angle. Once that angle of the eye is closed, the anterior chamber angle, the drainage of the aqueous humor, the water of the eye is regularly producing water and it is being drained out of the eye. That's why we say the pressure is maintained 19 and 20. But once these blood vessels develop over there, they again cause the same thing in the angle of the eye. They pull the iris, they close the angle over there, and the drainage is no more over there. The eye pressure starts building. Sometimes it goes up to 35, 40. And with that much pressure, what happens? It destroys the optic nerve, which we have shown earlier in the photograph. And when the optic nerve is damaged, there is no more messaging, the current going to the brain, and the patient can turn blind. So this is the whole story which I am trying to summarize, that how these blood vessels in anterior segment, in anterior chamber, when they develop in the iris, they close the angle over there, and they call this angle closure glaucoma, new vascular, new blood vessels, and the pressure goes up to 35, 40, 45, 50. And that pressure damages and destroys the good, healthy, pink optic nerve. And if it remains high, that becomes atrophic, white, dead optic nerve. And once the optic nerve is damaged, because these are nerve cells, they do not regenerate. Once damaged, it's gone. In the optic nerve, once the nerve fiber, the cells which are carrying the current to the messages to the brain, once they're damaged, they are not replaceable. They undergo irreversible damage. So this was about the new vascular glaucoma, one of the possible complications of proliferative diabetic retinopathy. Slide basically technical for the ophthalmologist to show the classification which we are using routinely. Same thing which I mentioned. Whenever a patient comes to me, I concentrate to see whether this is non-proliferative or proliferative. Then in non-proliferative, there is staging according to the severity. It be mild, moderate, severe, and very severe. That is quantitative analysis. And we see over there, if there is proliferative diabetic retinopathy, then we see whether it is early, high risk, there is hemorrhage, advanced changes, all these things we document. And the thing CSME, that is macular edema, clinically significant macular edema, its classification, its criteria. So this is technical classification which ophthalmologists use to decide what treatment they should start over there. Mild to moderate, usually we observe, we ask patient to control blood sugar level. We regularly follow 6 months, 8 months, 1 year, like this we follow. But if some things are going towards severe non-proliferative diabetic retinopathy, very severe, we start moving frequent visits. If we see very severe or severe and patient is non-compliant, the physician can, even in this stage, non-proliferative severe, if the physician sees that he is non-compliant and not taking good care and things are going in wrong direction, he can offer the patient, the role of lasers. And once proliferative diabetic, it is something very urgent. We do not delay. We take it as an emergency. We start lasers. We give injections over there. That is very important. Clinically significant macular edema, if it is present, it is not an emergency situation. We ask the patient to control blood sugar level, and we start injections, anti-VEGFs, and regularly follow. And on every visit, we do the OCT to see quantitative analysis, how much effective are our injections, and to control this fluid, edema, swelling in the posterior portion. So, respected audience, this was some brief description about the basic pathology of the diabetic retinopathy, how it happens, which organs in the eye are basically affected, what are current treatment modalities which we are using, and what is the classification. I hope my today's presentation will be beneficial for my respected audience and also for ophthalmologists in their clinical practice. I want to thank you for your attendance and attention. Thank you.